Welcome back, everyone. We are so excited to have Regina LaBelle, Acting Director of the White House Office of National Drug Control Policy, as our keynote speaker. She's a Georgetown community member as well, and an integral part of the O'Neill Institute. Before Shelley introduces her, though, I would like to introduce Shelley. So I'm not sure Shelley has come up meaningfully yet in this summit, which is not to diminish how critical she is to this summit. She's my right hand, she's my left hand, she might be my leg. One of the most talented and devoted people with whom I've ever had the honor to work, and I cannot thank her enough for her contributions to this summit. A little bit about Shelley. She's the acting director of the Addiction and Public Policy Initiative at the O'Neill Institute. She's an adjunct professor of law at Georgetown University. She focuses largely on the overdose epidemic, addiction policies, barriers to treatment for SUD, and public health approaches to drug policies. And she tries to marry that expertise with how law can be used to promote access to treatment and support recovery. That's her as a professional, and doesn't even cover everything she brings to the table as a professional. And I just can't say enough about her as a human, as a colleague, and as a friend. And I'm pleased to turn it over to Shelley.
And what a fabulous morning and event so far. This has really been exceeded all my expectations and been incredible. And I hope that everyone joins us for the interactive discussion at 1 o'clock, as well as the panels that dive deeper into some of these key issues that we've discussed this afternoon and tomorrow morning. But first, we welcome our keynote speaker, Regina LaBelle, who is currently serving as the acting director of the White House Office of National Drug Control Policy and doing incredible work there. Prior to joining ONDCP, she served as distinguished scholar and the director of the Addiction and Public Policy Initiative here at Georgetown Law and the O'Neill Institute. She also founded and directed a new Master of Science in Addiction Policy and Practice at Georgetown, which is currently in its inaugural year. Prior to her work here at Georgetown, she served at ONDCP in the Obama administration as chief of staff, and she also was legal counsel to the mayor of Seattle before that. She's also a Georgetown Law alum. And I worked with and for Regina LaBelle for several years here at Georgetown. And there are really kind of two things I wanted to say about her beyond her really impressive bio. One is that I joined Georgetown from working in state government for a number of years in the governor's office in New York and in state agencies. And before that, I worked as an advocate, actually suing the government to implement reform. And, you know, as everybody on this call and in this summit knows, it is hard to move the dial, even a little bit, whether you're doing it from inside of government or outside of government. And Regina LaBelle not only has deep subject matter expertise on these issues, she knows how to get things done. And that is a rare thing in this space. And she's really a true example of how the law and how lawyers can really make an impact on society and on communities. And the second thing I want to say is I'm also a person in long-term recovery. For me, that means I haven't had a drink or a drug in over 20 years. And I always think, like Brandon was saying in our previous panel, it's really important to share that at events like this, because we're talking about real people here. We're your neighbors, your lawyers, your professors, your friends, and with the right supports, not only can we recover, but we can thrive. And we also see the impact of addiction every day on our friends, in our communities. And Regina LaBelle is a tremendous ally to our community, never losing sight that in all of the policy decisions that are being made, there's a real impact on real people and families. And not only that, she actively engages people with lived experiences in those policy decisions every day. And that is rare indeed. I'm thrilled to hear her speak. She'll also be taking questions that I'll facilitate. So go ahead and enter them into the Q&A or the chat. And with that, I'll turn it over to Director LaBelle.
Thanks so much, Shelley. It's so great to see you on screen. And thanks everyone for this wonderful program. I look forward to watching the rest of it as I can later this afternoon and tomorrow. So I appreciate this opportunity to discuss the steps the Biden-Harris administration is taking to curb overdose deaths and build the infrastructure that's necessary to develop a holistic response to addiction in this country. And also to discuss how opioid litigation funds can help further the nation's work on this. So about a month ago, we recognized Overdose Awareness Week. It was declared by President Biden. And in his proclamation, he said, "Addiction is a disease that touches families in every community, including my own. The epidemic is national, but the impact is personal. It's personal to the millions who confront substance use disorder every day and to the families who've lost loved ones to an overdose. By enhancing our support for individuals facing substance use disorder, we can save lives." And we know our challenge has never been greater. The CDC numbers on overdose deaths paint a grim picture. The agency predicts that more than 93,000 people will have died of an overdose death in 2020, with almost 70,000 of those deaths involving an opioid. As Shelley said, these are not just numbers. These are our neighbors, our families, our children. And our communities in the country are counting on us to bend the curve on overdose deaths and help communities heal. When I joined ONDCP in 2009, there were about 20,000 people a year who were dying of a drug overdose, primarily driven by prescribed opioids. So at the time, as a growing problem, the Obama administration developed a response plan. We had record rates of opioid prescribing. We saw small towns in rural America flooded by prescription opioids. So one town that's become emblematic of the growing problem was Kermit, West Virginia. So Kermit is in Mindo County, West Virginia, a town that at the time had a population of 382 people. In a 2-year period, 9 million pain pills were shipped to this pharmacy. And I recall this distinctly. In Florida, illegal pain clinics were proliferating. You've heard the stories. A doctor would come in for an hour or so, sign prescriptions, people would line up, enter the office, and the office also dispensed the pain pills, and then they'd leave. And the person would either drive back to their home or fly on one of the many cheap flights that went back and forth between Florida and the Appalachian region. These pain clinics were not treating patients. They were operating criminal enterprises that led to unprecedented spikes in overdose deaths. And these overdose deaths suffered in some of the most forgotten parts of the country. This epidemic has evolved. The CDC discusses 3 waves of the epidemic, beginning with overprescribing of pain meds, then leading to heroin once prescription opioids were limited and people were still addicted, until finally a new, more lethal strain of opioid, illicitly manufactured fentanyl, entered the drug supply. And now we're seeing unprecedented rates of overdose death, primarily driven by illicitly manufactured fentanyl, but increasingly involving cocaine and methamphetamine. Still, overdose deaths continue to rise. While the opioid epidemic has evolved, so too has our understanding of the disease of addiction, and so have the tools we have to help people. So in the years I've worked on this issue, including at the Office of National Drug Control Policy and at Georgetown's O'Neill Institute, one thing has become abundantly clear. We must build a better addiction infrastructure to prevent substance use disorder while also meeting the needs of the 20 million Americans with substance use disorder and sustaining recovery for the 23 million people who are in recovery. So our efforts span the continuum of care, from evidence-based prevention to harm reduction, treatment, and recovery services. Also, our efforts include improving racial equity in drug policy and healthcare. And we also have to disrupt criminal networks domestically and internationally that traffic in drugs. Finally, we must improve services by making sure our nation's healthcare providers, including the medical community, fully understand addiction so they can better intervene when someone shows early signs of risky substance use that may develop into a substance use disorder. So as I mentioned, the latest national survey on drug use and health found that more than 20 million people who who are 12 or older had a past year of substance use disorder. We know that certain factors are associated with a greater risk of overdose, and this includes homelessness, injecting drugs, a prior history of overdose, race, and even geographic location, such as areas without access to evidence-based treatment. So I want to go back to Kermit, West Virginia for a moment. According to the latest census data, about 20% of people living in Kermit live below the poverty line. And about 80 of the people who today live in Kermit, that's about 335, are children. So these children are now more likely at risk for addiction because of the trauma that's been brought about by incarceration and conditions relating to poverty. Now, these conditions are not unique to people with opioid use disorder. Increasingly, overdose deaths are growing in other populations, including Black and Alaska Native American Indian communities. In fact, from 2015 to 2019, the highest prevalence of methamphetamine use was among Alaska Native American Indian communities, rather than what we traditionally consider a drug that's most often used in white rural communities. Again, these issues are evolving, and so too must our policy approaches. For example, we know that people with substance use disorder leaving incarceration are at heightened risk for overdose death. And Black, Indigenous, and people of color, pregnant women, and women with families face barriers to treatment that others just don't. For instance, it takes a Black person 4 to 5 years longer than a white person to enter addiction treatment. And too often, access to care in diverse communities is limited. Last month, we held a summit on this topic at the White House, where we heard from Shakita McBroom, who's an advisory neighborhood commissioner in Ward 8 in Washington, D.C. She shared her daughter's story and highlighted how difficult it is for young people to access the treatment they need, especially in the community where they live. Improving access to treatment is an opportunity where we can make a difference. So we often don't think of how policies affect people until we hear from people with lived experience. Earlier in the summer, I met a young mother in Western Maryland who is on methadone for her opioid use disorder. And she told us about her everyday barriers. First, there's a very real challenge of finding childcare so she can get to her treatment center every day for methadone. And she said her childcare takes up almost all of her income. In addition, she was very clear about the stigma she faces on a daily basis for being a person in recovery on methadone. So breaking that stigma surrounding addiction, this is another opportunity we can make a difference. For justice-involved individuals with substance use disorder, we have to prioritize diversion, treatment in correctional settings, and strong recovery supports. Because providing treatment during incarceration and upon reentry can bring down rates of overdose in communities, sustain recovery, and reduce recidivism. Right now, today, we can put policies in place and make investments to stop the continuous cycle of addiction that's fed by conditions like poverty, homelessness, and trauma. So at the federal level, President Biden has made it clear addressing the overdose epidemic and substance use disorder is an urgent priority. In April, the office released the administration's first-year drug policy priorities, focusing on building a stronger, evidence-based infrastructure to meet these needs. We worked closely with many drug policy partners to make sure our priorities are based on evidence and meet the urgent challenges that we face, reducing overdose deaths and building a strong foundation for effective evidence-based drug policy. So far this year, the administration has removed unnecessary barriers for prescribing buprenorphine to 30 or fewer patients. That makes it easier for physicians and other medical practitioners to treat patients with opioid use disorder with the standard of care. We've allowed federal funds to be used for fentanyl test strips, a key harm reduction tool, ended a decade-long moratorium on methadone bans, so treatment can be brought to more underserved communities. We've also designated 6 new counties as part of the high-intensity drug trafficking areas program, and funded the nationwide expansion of the overdose response strategy to all 50 states, Puerto Rico, the Virgin Islands, and DC. We provided funding for the development of model legislation for states to provide model legislation so states can pass laws that remove barriers to harm reduction services, as well as promote equity and access to treatment and drug enforcement efforts for underserved communities. ONDCP also sent Congress a legislative proposal on class-wide scheduling of fentanyl-related substances. This legislation seeks to reduce the proliferation of fentanyl-related substances while preserving civil rights and reducing barriers to scientific research for all Schedule I substances. The president is also working to send critical funding to states and communities to support this work. The American Rescue Plan delivered nearly $4 billion for mental and behavioral health. That includes $30 million specifically for harm reduction. And most of this money has already gone out to the states. Next year's budget request calls for $10.7 billion for the Department of Health and Human Services to address opioid use disorder. These resources, these tools, all help states, counties, tribes, and localities address substance use disorder locally. The investments, coupled with funds from the litigation settlements, will present a tremendous opportunity to make a difference. So legal tools, including litigation, can be used to garner the attention of the public as well as policymakers. And I want to emphasize the consequences of litigation that can drive change. We saw this specifically from the prior tobacco litigation. We don't see Joe Camel anymore. You don't have your baseball game viewing interrupted by the Marlboro Man, either on TV or in stadiums. And fortunately, you and your kids don't have to fly on planes or eat in restaurants choking back secondhand smoke. And most importantly, rates of smoking plummeted nationwide. There has been justifiable criticism about how the litigation funds were spent from the tobacco settlements. $200 billion and less than 10% went to state tobacco control programs. So practitioners, researchers, and advocates are urging leaders to apply the lessons from this litigation to the opioid litigation. I want to emphasize one success so far of the opioid litigation is the trove of documents on the opioid litigation that will be hosted by the University of California at San Francisco Library. These documents will be useful for journalists and researchers and give us the opportunity to learn from the past. The opioid settlements and the tobacco settlement are great examples of how the law and litigation can drive change. Law has the power to shape our policies and our lives in so many ways, from decisions of the Supreme Court, which was established on this date in 1789, to local districts and communities nationwide. And while law can drive policy, it has to be informed by science and community-based evidence. So we build the type of infrastructure that's so urgently needed. We know that settlement funds have begun to flow and will flow even more to states and local communities, and giving the mounting death toll from overdoses. It's important we spend these funds wisely. So of course, that's what we're here to discuss today. I want to suggest 3 ways to use these funds. First, it's really important that we identify the gaps and opportunities. Second, look at the evidence and build your community support. Third, evaluate and adjust. So first, begin by assessing your community's needs. Where are the gaps? And if you don't have this data, spend the money on getting the data. How many providers of medication treatment do you have in your community? And how many people are they treating? What are your rates of bloodborne disease due to injection drug use? Do you have enough data to look at the entire cascade of care, prevention, treatment, harm reduction, recovery? So start by figuring out where the gaps and the opportunities are. Second, based on these gaps, develop a plan to fill the gaps. Now, you are going to talk about and have probably already heard about the high-level excellent documents that are already in the public domain that include evidence-based ways to address these issues. But you know your state or local community best and can best identify where you need to go. Communities have to be brought along. Make sure to include people with lived experience, people in recovery, family members, as well as other members of the community, so they're as invested in the success of your efforts as you are. And lastly, make sure you build in a way to evaluate and reassess along the way. Are you reaching people at greatest risk for overdose? Who are we leaving out? So again, this work needs to begin today in anticipation of litigation funds. Now, about half of the states have already passed legislation that will guide how the funds will be spent. Some states are requiring advisory boards to oversee spending, while others establish trust funds that would serve as repositories. But there's still an opportunity to make sure that opioid litigation funds address the overdose epidemic. But there has to be planning, community support, and evaluation. As we near 5,000 overdose deaths in a 12-month period, the urgency of this issue increases. Using these funds wisely will help us heal and build the local, state, tribal, and national addiction infrastructure we need to bend the curve in overdose deaths. Thank you so much for first holding this event and for having this conversation and for being a leader in addressing the overdose epidemic. And thank you all for your service to your community and our country. And with that, I'll turn it back to Shelley for questions.
Wonderful. Thank you so much, Regina, for those wonderful comments. And we did have some questions come in, and if folks have other questions, please put them into the Q&A function or the chat. The first question is that, we had some comments, I think, throughout the first several panels that related to the challenges of short-term grants or one-time funding, one-time litigation monies, one-year budget cycles, right? We're kind of in short-term planning mechanism, and that does not lend itself to the kind of need for long-term planning that addressing this crisis requires. Are there strategies that the folks that are listening in can consider implementing in light of this kind of one-time or short cycles that really look to the future, that are forward thinking? Where do we want to be 5 years from now, 10 years from now, that kind of thing?
Great. Thanks, Shelley. So I think, we have to stop looking at this as an episodic thing. It's going to spike every once in a while that we have this urgent, overdose issue, as opposed to we have an epidemic of addiction in our country. And so what we need to do is make sure that our systems are built to respond to that, the chronic nature of this issue. So as good as grants are, and they can be very good, they can be very important for communities, we need to urge our policymakers to do a couple things. One is to make sure that parity is enforced, so that insurance companies cover medical, other physical care, as well as they cover addiction treatment and mental health issues, making sure that sustainable funding is in insurance companies and the Parity Act is enforced. And then secondly, also making sure that we don't overlook Medicare and Medicaid, that those are critically important tools, funding sources, the largest funding sources for addiction treatment in this country, to make sure they are adequately resourced to do that. And actually one example is Congress is considering right now an act, a bill that would provide Medicaid coverage 30 days prior to reentry, 30 days prior to someone being released from incarceration. So that's using Medicaid to address one of the biggest problems that we have, which is upon reentry, people are more likely to overdose. So making sure that addiction treatment, the addiction cascade of care, is included in all of our ongoing funding sources.
Excellent. And, kind of a piggybacking question on that, and this was also discussed in kind of the previous panel about funding that's come down, large investments over the past 10 years, SOR, grant funding, and others. And we still find ourselves in real challenges. And maybe this is kind of like too broad of a question, but how do we make sure that years from now, we're not spinning? We're not in the same place that we're in now with even larger investments, or, this constantly evolving epidemic, and get out in front of it. And, this new potential funding coming down through litigation, how can that be maximized to make sure that we're not in the same place, that this doesn't happen again?
Yeah, thanks. So a couple things. One is that we need to make sure these funds don't displace current funding, that they're not just used to to fund something else, that basically they're useful. They're used to build the foundation, and the foundation is not necessarily going to be the most flashy one-time, one-off program. It could be making sure that addiction treatment, identification of addiction is taught in schools of social work, for pharmacists, for nurses, for doctors, so that's building the foundation. And that stuff is going to pay off over the long term. Because if we have a whole cadre of healthcare professionals who are trained to identify, screen, and make sure people get appropriate treatment, we can avoid some of because what we do is we just treat the most chronic conditions, as opposed to identifying conditions before they become chronic. So it's really about not displacing funds, existing funds, and building a foundation for the future through education.
And then there's some questions in the chat around scheduling fentanyl and stigma. And I think maybe kind of I'll combine all of these questions together to ask. Sometimes, for me as a former policymaker, you do think that all right, this is the response that's needed right now, but there might be unintended consequences. And how do we kind of, as a community of government folks, as advocates, as lawyers, people working in this space or adjacent to this space, adopt kind of a forward-looking approach to not, we can't predict the future, but how can we step back from maybe putting out the fire day to day and really take a holistic approach to this issue, a forward-thinking or strategic approach?
Yeah, I think, having gone back and forth between, in government, out of government, things are a lot easier to make happen when you're out of government. Your thinking about how it works is a lot easier, a lot clearer than when you're in government, you're in the thick of it and trying to get it done. But so I would say, one is that people can't be afraid to get their hands dirty and really engage and find opportunities. If you want to build responses that are going to withstand changes in political cycles, you need to have bipartisan support. We talk, the harm reduction community talks all the time about meeting people where they're at. I think that's a lesson for the advocacy community as well, is to meet people where they are and to find ways to make common ground so that, these changes that are made can withstand political seasons. And I don't know if that specifically answers your question, but I think that, I think about this a lot. We're standing up a translational research branch at the Office of National Drug Control Policy. And the reason we're doing that is so that our work can be informed by the science and evidence that's out there. Sometimes science and evidence get smack dab in the middle of politics, but those are just realities that policymakers have to face every day.
Thank you. Thank you so much for joining us today. We really appreciate your comments. And I think right now we'll transition to our interactive discussion. I'll turn it over to Maria to introduce that. And I think we'll all get a link into the chat that you can click on to join, and people's faces will come up on screen and we can all have a conversation. Thank you so much, Director LaBelle. And with that, I'll turn it over to Maria.